Thanks. So this is, it's almost listening to Paris's talk. I think you have a lot of things that you could teach me. So I'm going to give you our, 2-year experience basically with eContour and some of the challenges that we have faced and some of our future directions and some of our approaches to the funding. So this is me, not actually me, but a picture that looks remarkably similar to me at the beginning of residency in 2013. It's sort of just a generic, looks like resident in a room with no windows, which is what we had. We called it the bowling alley. I was kind of like trying to figure out how to contour, and I was recognizing there were all these resources in various places. There were atlases, guidelines. Sometimes my co-residents would just say, well, why don't you just look at Dr. Eich's prostate case that was contoured last week. So, and some of the documented complaints that people have about finding contouring resources are listed here. So this is sort of the foundation of this project, econtour.org. One of the first things that we asked ourselves was, well, would this improve outcomes, or can we prove that this could improve outcomes and try to get funding to do it? So, it turns out when we've been looking at in randomized trials of radiation over the last couple decades, there's been a number of publications basically showing that in randomized trials, patients that are getting treated and have protocol deviations lead to worse survival. And so there's actually a meta-analysis looking at that focused on head and neck, GI, lymphoma, that kind of comes to this conclusion. And so the next question is, well, what are the protocol deviations? So this protocol deviations have historically not been cataloged very well. There's not specific criteria about what necessarily means a deviation, although it's getting better. But this is the Trago 202 study, which you may not remember because it was testing terpazamine, so it was a negative study, but they actually pretty well defined deviations. And they found a 20% difference in overall survival at 2 years for head and neck cancer patients that were treated protocol compliant or with deviations. And they actually did attribute 25% of these deviations to contouring or field design because it was largely 3D conformal even. So and these deviations, this is sort of important, we're actually seen in low volume centers. So 30% of patients treated at centers that enrolled less than 5 patients actually had deviations, whereas if your center was treating more than 20 patients, they had only 5%. So that was pretty remarkable. And then it's been kind of this issue will come up more is this idea of specializing and treating high volume. Probably it's just easier to keep up and easier to be comfortable with the data, particularly in head and neck cancer. So we have all these, increasing complexity of our radiation treatments and a number of trials actually proving the benefit of these complex conformal therapies. So the question is, how are we implementing these techniques in practice, or how are we teaching them? How are we learning them on the job? And so contouring education, obviously now it starts in residency, and this first publication that was actually mentioned earlier is actually my chair, Dr. Munt. They did a survey, and by the early 2000s, up to 98% of residents in the US were saying they were getting hands-on IMRT experience, which is pretty good. But, follow-up is more like this study from Dr. Jaswal in Canada was pointing out that, well, actually formal contouring training in 2015, only 20% of residents were, endorsing formal training. And then Dr. Nabavizadeh, who's actually here today, helped run this ARO Chief Resident Survey that looked at just asking residents, like, what do you feel is sort of, adequate in your residency training? And obviously physics and rad bio, where we have exams, we have formalized education around, people are quite satisfied, but radiology and anatomy is coming up sort of lower on the satisfaction. So there's definitely still, even in the in the last couple of years, an issue in the U.S. among residents with their confidence and their satisfaction with education in this area. And so at the same time, I plotted out like the consensus guideline publications, just really crudely, to show that we have a rapidly increasing number of publications that are supposed to help guide contouring, and this mimics. This was sort of mentioned earlier, and this actually was Richard Zane had brought up at Astro's keynote last year. there's this idea that medical information is increasing, it's increasing rapidly, and like how do we deal with all of this information that we're getting? So that kind of leads us to the concept of eContour, which is really to bring all these resources into one place, make it easily accessible at the point of care. Here I'm just showing you a brief video for those of you that aren't familiar, but it's disease site based, and then within each disease site are the most common presentations that you would see, and it's an actual case that was treated. So it's showing you that you can turn the OIRs on and off, you can turn the targets on and off. On the right-hand side of the screen, it describes the prescription basically that this patient was treated with, and allowing us to kind of scroll through and manipulate this basically DICOM set that's been converted to JPEGs. You can overlay the dose distribution to see kind of what an adequate dose would look like, and then you can also overlay some of the diagnostic imaging that you could fuse if you wanted to. And then the last thing I'll point out in the video is just we also incorporate anatomy because a lot of our contouring guidelines actually describe specific anatomic features that, you know, people that are just learning how to contour or learning 3D anatomy may not be as comfortable with. So to help kind of bring that to more easily accessible when you have to contour a patient, to learn the anatomy at that time. So the first thing we actually did was to test this tool in a randomized trial, and this is kind of where the ROECSG comes in, and we actually across 5 centers had residents. There were 24 residents. They contoured a nasopharynx case just with any resources, and then they were randomized to contour with eContour or again with any available resources. And what we found was that we improved the contour agreement with the expert as well as with the consensus on the high-risk CTV, which was our hypothesis based on data from Beckelman at Memorial, that was kind of the most variable, and that and the contralateral parotid. But also, on an education front, this idea of education at the point of care was that eContour improved knowledge of some basic knowledge-based questions, but also when we asked them to contour certain anatomic features, they were able to do that better. And we looked at both the actual contours and then just a visual evaluation. So then we also asked them for usability, and on just a 10-item questionnaire, which we had them, the textbook, we realized over 50% of users were using the Nancy Lee's textbook, so we had them sort of look at that ad hoc, but just to kind of prove that there is, people are rating a website more usable than a textbook. So this is our dissemination data. Most recently, about 60% are physicians, and the red is showing the residents make up a significant component of that, and this is sort of early on. The average case page view is about 3 minutes, which is similar to medical literature, actually, that people look up answers for about 2 or 3 minutes. I won't go into too much detail. I'll mention the simulation we talked about earlier. This is Michael Rooney's paper, but kind of thinking, how can we get into this? So eContour 1.0 is what we're calling our reference resource, where you can go, you can see the case, you can use it to help guide. But we've developed kind of a more interactive component to be able to collect data from users about how they're contouring, and then actually be able to give them feedback. So you can actually go, this is not password protected, to this econtour.org/acro, and we have 5 sort of test cases. Right now you can only contour on a single slice. It's very simple. And we piloted this at acro, and basically showing that you could use it in a conference setting where all the users contour, and then have the users be able to see on the right what their contour looked like compared to the expert. And then this is just showing it ended up getting used in boards, and that brings me to the conclusion, really, that we know that contouring impacts outcomes, and we're kind of, through eContour, developing these 2 components. One is kind of what I'm calling education at the point of care, and then the other is really simulation and using that to provide feedback and potentially for evaluation purposes as well. So I'm happy to, this is my team. So we're funded by the various professional organizations largely, as well as the AHRQ has been the most supportive of this project as a sort of quality initiative and quality and safety.